was working, taking some clients. They'd been out for safari, driving home, and there was a trail of blood along the side of the dirt track. And he thought, that was probably just a lion, some prey, some wounded animal or something like that. But sadly, he then caught up with what the Virtual Doctors does is essentially provides these clinicians with smartphones and an app. The ability to submit a case, and it then comes through to an NHS doctor. We give them some advice.
Daniel, it's a pleasure to have you here today, sir.
Yes, thanks so much for the invite. It's really good to be here.
Tell us a little bit about yourself.
Yeah, so where to start, I guess. So I'm a GP by background. I suppose I'm what you would call a portfolio GP, which means I do a bit of general practice, which is important, obviously, for the NHS and for patients and things like that. But I'm more interested in going off on expeditions, doing a few exciting things, which is partly what we're going to be talking about as well. And then within that, one of my main interests is global health, which kind of links with the Livingstone Expedition that we're going to talk about, but also my role as the medical director with the Virtual Doctors charity. And yeah, I mean, that's it in a bit of a nutshell. I do a bit of medical education as well, teach on some expedition, wilderness medicine courses, things like that. Basically, always looking for something fun to do. Hopefully, it's outside. It's nice if it's in an exotic location, but it's equally cool in the Brecon Beacons, like in South Wales, which is where I live. So, yeah.
So what was your passion? What ignited your passion for medicine early on?
So that's an interesting story, actually. So I think, like meandering through school, I wasn't really sure what to do, which I think is common for a lot of people, particularly when 17, 18 or whatever. And I actually thought about becoming a vet, which is people are like, okay, that's a bit weird. But someone at some point said, oh, well, veterinary medicine's quite difficult to get into, which I think it was at the time because there's not so many vet schools. They're like,
humans, far less complicated.
Yeah, so they were like, why don't you think about humans? And I was like, yeah, fine. So I did a bit of work experience, and then before I knew it, I'd gone through medical school and I was a doctor. And then you're sort of thinking, okay, well, what am I supposed to be doing with this? And I was never I did all my different rotations and different training and things like that. And I wanted to keep doing something that was quite generalist so that you could have that knowledge and skills to apply to lots of different situations and things. And then, ended up doing general practice training, and then got to the end of that and thought, that's great, but I can't see myself sitting in, a GP consultation room from now till when I retire. And I get that is what a lot of people do, and that's fine. But for me, I was like, that can be part of the role, but it can't define me as a human. There's too many other things I want to sort of go and do. But that baseline medical knowledge and experience obviously gives you the background to then go and do some of those other things, and that's what's helped kind of jump into the expedition stuff, some of the global health and other things I do.
Yeah. Where does Virtual Doctors fit into this whole picture that you've painted?
So
as well?
Virtual Doctors is a very interesting. So it's a voluntary role for me. It's a charity that I've been involved with since, I'd like to say 2017, 2018, something like that. And the Virtual Doctors are an organisation that was set up by a chap called Hugh Jones. He's actually coming on the expedition with us. So he's not medical at all, and he's also not technological at all, which is quite interesting. Bear in mind that we're a telemedical charity. So he's neither of those things. But what he used to do back in the 80s and 90s was he was a safari guide out in Zambia and Malawi. So he's a real expert when it comes to that side of things and these, the nature, the geology, geography, all those kind of things. And when he lived out there, he sadly witnessed quite a lot of possibly preventable death and disease and things like that. And he was like, there must be something I can do to help. He had that kind of epiphany moment of like, what can I do? And then he didn't necessarily know that the Virtual Doctors was going to be that end point, but he knew that he wanted to do something. And he always tells this story, which is quite sad. But he was working, taking some clients. They'd been out for safari, driving home, and there was a trail of blood along the side of the dirt track. And he thought, that was probably just a lion, some prey, some wounded animal or something like that. But sadly, he then caught up with a man just on a cycle bike with his wife on the back, who was heavily pregnant and sadly bleeding due to pregnancy complications. And he sadly tried to rescue her, put her in his truck, take her to the hospital, but it was too late. And Telemedicine probably wouldn't have changed that particular outcome, but I think it was that light bulb moment to sort of think, okay, what can we do? Can we help? And if you fast forward to now, so Hugh set up the Virtual Doctors charity. We've been working alongside the Ministry of Health in Zambia for sort of 15-ish years. I think that's really important to emphasise, because it's not a case of us just going there and saying, look, this is what we think, this is what we want to do. Yeah, I think you have to be really careful of the optics of just going and sort of having that perceived we are the experts. So it's never really been like that. It's always been designed from the bottom up to support the clinicians in the field. So we support clinical officers. So the equivalent here may be sort of a nurse practitioner, so someone who's got a good general medical basis, but they'll have done maybe a year or two's training.
Okay.
And then they get sent to these rural areas to essentially deal with everything. And they're amazing at dealing with all these things, but understandably, like me as a GP, sometimes I'm like, I don't know what this is, or I just want to discuss this, or need a bit of advice, or the patient needs to go, it's the next level of care. And historically, what would happen is that that's potentially a day or two's travel. And hence that story I was saying about. And sometimes, obviously, that needs to happen. But sometimes if you can get that advice remotely, then that can save the patient a considerable journey. Because those journeys often come at personal expense, have to maybe take your family with you. And then you sometimes have to decide between your livelihood. So a day going off to visit the hospital versus a day's work might not be viable, for your family situation and things. So all these things that we probably don't think about if we're going off to see the doctor, in the UK and things. So what the Virtual Doctors does is essentially provides these clinicians with smartphones and an app and the ability to submit a case, and it then comes through to an NHS doctor. We give them some advice. Sometimes it will be, yes, actually that patient's, they need to go for XYZ test, but a lot of the time we can then give advice that stops them having to then go for the next, next level. And a lot of that is then, okay, the next time a case comes in with that same sort of presentation, then that clinical officer, healthcare professional knows what to do. And the idea is always that it sounds a bit strange, but we're almost trying to put ourselves out of business, because if you make that model sustainable and you actually cascade that knowledge, then fewer cases come. And some people think, well, surely if fewer cases are being sent, you're being less successful. But no, I think that's quite an important measure of success. And then the other thing is, because the other thing we get asked a lot is, well, it's all very nice you being NHS doctors and answering all these cases and things, but what about Zambia? What about Zambian doctors and things like that? So I think the important thing is that it's always been like a Zambian solution, if that makes sense. So yes, at the moment, whilst we sort out logistics, because the main issue is that per capita, there just aren't the same numbers of doctors. So in the UK, I know we struggle to get GP appointments, don't get me wrong. It's about one doctor to 350 people, whereas in Zambia it's 1 to around 12,000.
I mean, it just really highlights and puts into perspective kind of, as you said, things may not be quite ideal here, but it puts into perspective when you amplify those numbers to that degree.
It does, and that's part of the issue when we say, oh yeah, we'd really like to have Zambian doctors working on this platform and giving advice. Of course we would. But then we also have to bear in mind that reality. But the plan sort of over the next few years is to, once we sort of upscale the platform, is to have clinical officers, then Zambian doctors, because obviously they've got the knowledge, they've got all the networks and things like that. And then we will be here as like a backstop, but more of a just in case thing. And then we take that whole model, we take it potentially out of Zambia because it's already embedded there and hopefully becoming self-sufficient, running itself. And then we look somewhere else. So Malawi is our main next kind of target, if you like. So we're doing some pilots there and things. So it's all quite interesting. And that's just one of my many roles that kind of goes on in the background, if you like.
It's incredibly interesting. And I love the way that you phrased it in terms of how you think of it as support and empowerment, as opposed to coming in and just providing your lens on this is how we do things and this is how you should therefore do it. Because that, that very quickly optically becomes something quite insidious in terms of, that white savior going in
100%.
Taking care of things and being like, we're going to do it our way.
Yeah.
And you'll listen to us. Thank you very much. Which is not at all where...
So it's really difficult. Conscious that, two white people just discussing this. And that's one of the things we've had to be careful about, both from the charity side of things, but also with the expedition as well. So yeah, it's no secret the expedition is called Livingstone Revisited, and we'll talk a bit more about that. But then you go into that whole kind of colonialism, how does that look? But I think with the charity, the most important thing is that, like, so our executive director, he's originally from Zambia. We've got a Zambian board in Zambia. We're registered as a charity in the UK, but also in Zambia, and so it's been built up organically from the ground, which means that so we started off actually looking at off-the-shelf sort of telemedical type systems, and it just wasn't suitable for the sort of the clinicians we were working with, because various idiosyncrasies just didn't work, and they were like, well, why do we do it like this, this and this? And similarly, we tried loads of different tech options, and ultimately a simple smartphone it's actually all text based it's a bit like WhatsApp almost, but you can send it. It's a bit more secure than I know WhatsApp has issues, we don't really like sending patient things through WhatsApp and stuff, but our new platform, which has actually just been completely revamped, has the ability to do text-based cases and images and things, and then start a discussion, which is really important because video calls, there's just not the same data bandwidth. I know everyone over in the UK and other places, Zoom calls are still difficult, even if you've got like fiber optic broadband. So if you then take that to somewhere where you've got 2G, maybe a bit of 3G, 4G, it just doesn't really work. So being able to like drip feed lower data bundles through our tech, it makes it a lot easier, because otherwise you can have the best will in the world, but if the connectivity isn't there, then it doesn't really work.
Yeah, and that's something that I know we've got a mutual friend and connection who is obviously accompanying you, who has some experience in kind of telemedicine and solar powered communication masts and things like that, which does provide an amazing ability to get that greater degree of connectivity, and then be able to patch people in from, as you say, the UK and other university hospitals in the States, in Scott's case, when he was talking to us about that.
Yes, Scott is coming, so that'll be really cool actually. So we met up in Edinburgh at the World Extreme Medicine Conference, probably 2 years ago, and we did like a joint kind of session there. I kept in touch, and he's coming along with Alice, who is he probably told you a bit about Solite, the company that he's involved with, and they're excellent. So they're coming out for the second part of the expedition. But throughout the whole trip, we're going to be essentially providing solar lighting and solar power. I guess that kind of brings us on. I keep talking about this trip, but I haven't really said what it is.
Yeah, well, tell us a little bit about the Livingston expedition and the Livingstone's Trail, and what you're going to be doing whilst you're on it.
So so this all comes back to a discussion that probably happened during the tail end of COVID and the pandemic and stuff. So Hugh, the chap who set the charity up, and he used to be the executive director before he sort of stepped back to focus more on his family and stuff. But we'd always have like weekly meetings and discuss about things. We're like, it'd be really nice to go first off and visit some of the clinics, because I'll admit, I've not been to Zambia. So I've worked in similar low resource settings, but so part of it was like, it'd be quite good to go and visit the clinics as the medical director and just understand things a bit more. And Hugh was very much, I think, yearning a bit after some of that old adventure and the stuff that he used to do. And I was like, that's all very good, but if we're doing something like that, I think we should try and make it so it has some objectives and some positive
it has to be more than just a little jolly.
Precisely, and that's something that we've been really conscious of when sort of designing and planning, because to an outsider it can potentially look like that. So what we're doing briefly is the distance has changed slightly, but it's somewhere between 2,000 and 3,000 kilometers overlanding in land cruisers, going from clinic to clinic, and the thing, not all the clinics, because we support about 300 of them, but certain clinics that fit to this route, because we've only got a 3-week time frame due to various reasons. But essentially we're going on this circular route, and the thing we really wanted to do was, first off, was compare some of the disease epidemiology and ideas in current day with Livingstone's day, which is not the easiest thing, because obviously records from back then and indeed records now are not amazing. But
one thing I was also actually going to say, give us, who is Livingstone?
Take
us right back to the beginning.
Us right back.
Give us the educational course.
I think Livingstone he's only really known of, that famous catchphrase, when Stanley found him, Dr. Livingstone, I presume.
Yeah.
And everyone knows that, but everyone doesn't really know much about him otherwise. So he was born up in Glasgow, in Blantyre. There's actually a museum up there. You can go and visit his birthplace, find out all about who he was. But essentially, he trained as a doctor. But his main calling was kind of a mixture of medicine, but he was also a Christian missionary. And he was sent out to Zambia. Various different countries in Africa. He spent a few years, most of his life traveling around, and that's why part of the expedition goes to some of the places that he went. So there's not a trail as such. So we're going to Livingstone, which is understandably named after him, and there's a memorial on the route where he died during one of his later trips. But yeah, so what he did basically was he went out initially to spread Christianity, and yeah, for full disclosure, the expedition isn't a Christian expedition; it's completely secular, open for everyone, and similarly with the charity. But there is that link to that was what Livingstone did. But whilst he was out there, he was very much he was interested in the culture out there. He was interested in exploring and ultimately finding out about resources. And this is where that potential issue around colonialism, white saviorism kind of comes back, because you're like, well, was he there and did he start that whole exploitative scramble for Africa? Not exactly, but indirectly, he opened up those ideas potentially.
It's unfortunately the law of unintended consequences.
I think
Livingstone most probably went out there with every will in the world to spread the mission of religion, to do something like provide medicine and all of that sort of stuff wherever best he could serve.
Yeah.
And unfortunately, when you're writing about where you've been and the resources that people have and what you're seeing, obviously, it becomes the new El Dorado. It becomes the new place that people want to.
That was the issue, and he got quite a lot of support from. So he did a few expeditions. He had one particularly successful one, and he was awarded. He had a good recognition by the British government and the Royal Geographic Society and people like that, and that was good for him. But then some of his later expeditions didn't go so well. He tried to go up the Zambezi, but he hadn't worked out how shallow it was, so he had ordered all these boats from the Royal Navy, and they just couldn't get there. So then his reputation sort of went down a bit. He had to deal with malaria, quite severe malaria. He had loads of medical issues eventually, which caused him to pass away when he was trying to look for the source of the River Nile. But so he's often thought of as almost a failed explorer, because one of his trips was really good, but some of them weren't so good. But I think the key thing, and the reason why he's perceived in a positive light, certainly in Zambia and Malawi, compared with a lot of his contemporaries, perhaps, is that he was very much involved against trying to abolish the slave trade. So he worked to try and raise that awareness, to try and say, look, hang on, what's going on here? This isn't right, through his writings and sort of through his reputation. And actually the reason he went and did some of his later expeditions was well, if I find the source to the River Nile, that'll make me pretty famous, and that prestige and reputation will give me that voice to potentially help end the slave trade and things like that.
Yeah.
So I think that's why he's viewed in maybe a slightly different way to some of his contemporaries, and that's because we've had people being like, oh, that's not a good name for an expedition, because he's a Victorian explorer and the whole kind of potential connotations.
Yeah.
But at the same time, I think part of it is it triggers this dialogue. It triggers these discussions, and that in itself is
I'm 100% with you. I mean, America has its own issues with similarly Abraham Lincoln, in the fact that you kind of pass over the amazing stuff that he did do in grouping him with a bunch of other people that were not so morally kind of aligned.
Yeah.
But I would, in this instance, take Livingstone as what I would interpret as a good man who wanted to spread a message that he thought could benefit people, to deliver medicine where he thought it could benefit people.
Yeah.
And, that explorer's mentality to discover more beautiful places on the planet. And personally, I would leave it at that.
Yeah, I think that's what we're doing to an extent as well. And we're gonna we'll all, I think it's always important to have that dialogue about, you can't erase the past, can you? Like, these things happened, and you have to be open to, people are going to ask questions about, if you're doing an expedition and it's linked to that. and you're a charity that's based in the UK, well, and also Zambia, and you're starting to do these things that, like we were saying before about the white saviorism and things. But I think if you pick up on the key bits of Livingstone's legacy, then actually you can get some quite interesting things. And that brings us back a bit to the fact that he's a missionary. So whilst it's not a religious expedition, we were very much looking at, like, how can we kind of create an interesting narrative here? So like I was saying, the idea for it came when me and Hugh were having these chats about, it'll be nice to do something. And that's when we noticed that actually a lot of the clinics linked into some of those kind of key, not like the trail or a particular expedition, but various, in different parts of his life, there were kind of key sites that he went to. So there was one where he sadly passed away. There was one where his dog unfortunately got killed by a crocodile, and he lost his medicines chest at another place. So there's some interesting kind of bits. And then as we were sort of doing that and working out our route, we thought, and this was probably in conjunction with Scott Johnson, actually, we were like, actually, we're kind of becoming digital missionaries, which is a term I quite like. It's not a religious term at all, but by connecting people, by using telemedicine, by, through the virtual doctors, we're providing digital connectivity, and in a way you're sort of spreading a different type of missionary style, and it links to the light. So Scott's idea of the solar lanterns, so we're now going to be providing the solar lanterns to all the clinics, and moving forwards, hopefully we'll have a really good partnership with Scott as well. And that's really important because there's been so many issues with drought in Zambia at the moment.
Yeah, I was going to say, one of the things that I'd wanted to just briefly touch on is paint that picture for us of what does a day in the life of someone living in Zambia typically look like? What are the challenges that they face? And really lay that out in a format so that we can truly understand, where the work that Scott's doing, where the work that you're doing and Hugh's doing, and the rest of the people involved in the expedition is going to make that impact.
Yeah, I mean, so this is a very politician's answer. I guess there's no one answer,
No experience.
I think we have to be careful that, and this links with some of the cultural issues, I guess, and that we have to be careful that we don't just say a stereotypical Zambian is X, Y, Z. But yeah, so obviously some of them will be. I think the main issue is the first of the doctors. How I said that the density per capita is just not
12,000.
ideal. Yeah, but the other issue is that a lot of the population are rural, and a lot of the doctors and medical facilities are in urban areas. So that's kind of the main issue there, and a lot of it depends obviously on the population. So a lot of the clinics that we support, it's subsistence farmers, and I think the main issue is just having that access to healthcare, and if you can empower a rural community so that they have, the ability to get remote advice. They also have safe lighting, so if you go to the clinic during a drought, and it's dark, or you can or you just need lighting to properly examine a patient, then you can have that. I think those are sort of the main challenges. But then, in the more urban areas, then it's not that different necessarily to here and things, and that's
with a lot of the people that don't necessarily have that access being subsistence farmers. Are there particular challenges with wildlife, for example, and things like snake bites or
so interesting you say that. I think one of the there's a huge amount of issues, I suppose, from a tropical medicine perspective that we just don't get over here for obvious reasons. Snake bite is one of them, and it's one of the neglected tropical diseases on the WHO's kind of list of priorities, and it's often sort of forgotten about for reasons that are unclear. Because if you look at the statistics, a huge number of people suffer from snake bites and potentially die fairly quickly. But then it's also, if you don't die from a snake bite, you possibly have life-altering injuries. So whether that's disability, contractures of the muscles, things like that, reasons that you can't function, and can't get an income potentially. So snake bite is an issue, and that's partly why that's one of the areas we're looking at during the expedition. So we're teaming up with an organisation called Snake Safety Zambia, and we're going to be launching a few different things. Mainly as a day of training, a bespoke training package for some of the clinical officers we support. We've chosen to sort of focus on a smaller number, but give a good quality training, and then try and develop sort of a package so that we can then follow up whether the training has had an impact. Because I think, like with the whole of this, if it doesn't have an impact, there's questionable reason for doing it. So we want to then look at, is the training going to, because the main thing with snake bites is that depending on the snake, and you don't want to go chasing after it to find it particularly, but depending on the snake, you treat it quite differently. And different what's called a toxidrome, so based on whatever the venom is, will have a different consequence. So some will cause nerve paralysis, which will eventually affect the diaphragm and stop you breathing. So that's obviously managed in one way. Others will cause, so I got bitten on my leg. It doesn't spread to the nerves, but it will cause nasty necrosis and cause all the sort of the skin and the flesh and the cells to die.
Yeah.
And then some of them will affect the blood, so affect your clotting and things like that. And then some of them do a bit of all of those. And the challenge is obviously working out which does which, and then instigating sort of a protocol or some sort of training that helps clinical officers say, okay, this has happened, I need to do this treatment and go down that pathway and things like that.
Yeah. I suppose in some of those cases, that's relying on hopefully the first-hand account of what was the snake that bit you?
Yeah.
Or what does it look like? Tell me.
Yeah, exactly. And then the difficulty there is that you don't always have that information, isn't it? And that links a bit with some of
the light was one of the things that I was thinking.
Yeah, precisely. So actually, if you have good lighting, you'll hopefully see the snake and not get bitten. In the first place, exactly. So yeah, lighting. And then the other interesting thing, which it could be a whole segue for a discussion, and I'll admit I'm not an expert, but then the discussion is antivenom as well.
Yeah.
So there's always the discussion of, well, how does antivenom come into that whole scenario? And often, well, the main issue is that there's nowhere in Africa really makes antivenom. Most antivenom is made in, I think, usually India or the Indian subcontinent, and then shipped in. And the thing with antivenom is that it has to be specific for the actual snake. So there's not like a universal antivenom that you can say each targets every snake, if you like.
As you say, each individual venom has its own tox profile.
Exactly.
Hence the different symptoms that you get as a consequence of being bitten. So each antivenom has to be developed, as you say, individually for the particular snake
and
that's bitten you.
Then there's the cost that comes into obtaining it, and then potentially the cold chain. So you can have a huge amount of stuff, but if you can't store it properly, then what do you do with it? And similarly, if you give antivenom, because antivenom is made by injecting the snake venom into a horse, normally a horse, and then you take the blood out of the horse, centrifuge it down, extract the antibodies, and then that's what gets injected into the person that's been bitten if they meet the criteria for needing the antivenom. And you can imagine that we may have allergic reactions when we're injected with horse antibodies. So there's a risk of anaphylaxis and things like that. So these are all the things that we're trying to touch on in that training, but also look at how that training hopefully impacts on better outcomes, so that then we can say to the Ministry of Health, look, this is so doing this as a pilot essentially, with a plan of then rolling it out over other districts and then eventually across Zambia. Because I think it's important, like we were saying before, to have some. We've got a few different legacy things linked to the expedition, but the snake bite thing is one of those. Yeah,
and I think that's really lovely as a way of explaining, at least in part, the mission that you're on to do this, because I think that I even think about how much knowledge you've just shared in this couple of minutes conversation, things that I didn't know, that snake antivenom, for example, was developed by injecting horses, and that it was their antibodies.
Yeah.
So, even just that, you expand that out into a whole different other range of areas across medicine.
Yeah.
It becomes something really, really valuable, really powerful, really profound in helping support people in the way that you want. What are some of the other objectives that you have with the Livingston Expedition?
So there's that one. There's another training objective as well. There's the snake bite for like a 1 day, and then we're doing 3 or 4 days of trauma training. So the other thing we get a lot of cases through. Because the nice thing about having the virtual doctors and our telemedicine thing is we know since our last app that we've just retired was live since 2016, 2017. So we have a huge amount of data, and we know what kind of cases come in and things. So and particularly trauma, so road traffic collisions, things like that. So being able to, and that's when sort of the first aid principles in low resource settings is quite useful. So we're doing some trauma training. We're quite lucky. So my colleague Ben Lyon is coming along. He is a paramedic, and he's just left the Royal Marines. He's got a lot of experience of that sort of, doing that sort of thing in low resource settings. So we're going to be running some trauma training, again, looking at cascading that down, because what we want to do is, yes, it's great that we can do a few sessions, but actually we will pick some people in advance and train them as we're doing it, if that makes sense. So the clinical officers with more experience will then sort of upskill them to then deliver those sessions and cascade them, because we can't train everyone in a 3 week period.
And you're only there for 3
exactly.
weeks, and no one place for a long time.
Precisely, but the idea is that we cascade that information down, and then hopefully we see positive outcomes from that. So those are the two education things. We touched on it briefly, but yeah, providing the lanterns is another thing, because Zambia is having huge issues with power at the moment. So there've been lots of droughts. Can't remember the numbers off the top of my head, but basically one of the lakes so our route is sort of fairly circular, and then it drops down to near the Zimbabwe border, where there's a lake called Lake Kariba. And that's pretty important because it has 2 dams, one at each end, basically, one which provides most of the electricity for Zambia, and then the other one provides most of the electricity for Zimbabwe. And the issue is that the water levels on the lake are something like 13% of what they should be, which means that the amount of power generated for the country is a lot less. I can't remember what it is in terms of megawatts and things like that, but it's a significant number to the extent they have to power ration.
I think in some of the documents that you shared previously, they're down to something like you can have 12 hours of power per day, and then you're on your own. Exactly,
yeah. So they're having to have a long time without power, and I mean that's inconvenient at the best of times, but if you're trying to run a healthcare facility, it's even harder. So that's, and I'm not saying that we're going to be able to sort that whole thing out. Of course we're not. A lot of that is, climate change, and there was an interesting quote from the environmental minister in Zambia saying, look, Africa has so little output from the emissions and things like that, but is suffering a huge amount of the consequences, and that's a really difficult thing to get across. And we're hoping that's partly why we're having our sort of making a documentary of the whole trip, and that's partly to raise awareness, yes, of the virtual doctors, but also the issues that are affecting Zambian clinicians and patients and impacting on their access to healthcare and things like that. So yeah, providing solar lanterns, but also, so you probably know, but so Scott and Alice have these lanterns. They fold down a bit. They're based on origami. They're super cool. But they can also charge devices, which if you're doing telemedicine is quite useful.
And if I'm not mistaken, they can also be daisy chained as well.
I think so. Yeah. So that's really good. Purely from having, because you identify a healthcare centre as a place of safety, but if it's pitch black, that might not be so good. So being able to examine patients and just having that power, but also staying online is quite important. If you're wanting telemedical advice, but you can't charge your phone because it's blackout for 12 hours, then that's difficult. So we're sort of trying to collaboratively link these things together and do that. And then the Livingstone thing is, I suppose, is the theme that sort of knits it all together, bringing it back to that sort of idea of digital missionaries spreading the light. So there's a few metaphors there, and it links a bit with sort of historical adventure and things like that. But part of the Livingstone idea was actually to get people talking about the expedition in the first place. And like we said earlier, potentially there is a bit of controversy. I think you can't just ignore history, but having those dialogues then gets people talking about, okay, those were some challenges there. Has malaria, for example, has the incidence of malaria and things like that, which David Livingstone eventually died of severe malaria and internal bleeding and various complications. That was quite a long time ago, like the 1870s. But actually, how much has that actually changed? Hopefully it's changed a bit, but what are the challenges that still exist and how do they compare? And it gets us all thinking and gets people interested. And that's part of the reason why we're doing the whole thing.
And that is a very interesting point. And it's something that I spoke to Elena Mills from the South about with regards to neglected diseases.
Yes.
And obviously, we all know, by and large, unless you've been living under a rock, malaria. Yes. There's other conditions like leishmania, for example, that people don't have that much familiarity with, but they affect huge swathes of the population. But because it's not in Europe, it's not in America, it's
yet being the key word, probably.
Exactly. There are recorded cases in southern parts of Italy.
Yeah.
So, that geographical region of those conditions is expanding. And these are things that we've ignored probably for a long time because it hasn't been on our doorstep.
Yeah.
And also, to the point about how those clinics are so spread out and the access to that, I think people by and large forget just how vast a continent and the countries that exist within that continent, Africa is. It's huge place.
Yeah, some of and that's one of the things that sort of when we came into the logistical aspects of, okay, we've got 3 weeks, we've got these objectives. How's that going to work? That was the logistical aspects of the expedition and the planning stages have probably been going on, certainly in my brain, if it seems like forever. But I think it's probably taken a good 12 months, because that is so much to work out. And that's where the distance is. It's like, we're doing 2,000 or 3,000 kilometers purely because, everything's a long way.
Yeah.
A long way away and things. But, you're really right about that. The fact that the tropical diseases, if we're not careful, are going to come. I think they already have, it was in the news a few months ago, the tiger mosquitoes that have come to Paris. I think they carry chikungunya, which I think is another neglected tropical disease. So, we do need to be careful. And sort of see. And it helps having that discussion as well, I think.
100%. And it was one of the things that Elena mentioned as well, in the treatment. Because actually the treatment for leishmania is awful. Actually, in many cases, you feel worse from the treatment than you actually do from the condition itself. Yeah. And that purely, to my mind, and this may be a very pessimistic, let's put it that way, lens on things, is we've just not innovated. We've not innovated on those conditions because they don't make sufficient enough money. Let's just put it that way. And that's my pessimistic view on things.
I mean, if we're being cynical, but how cynical are we being? I think it's true. Because you could argue the same, and that's why there's not a huge amount of funding into snake antivenom. So,
who does it affect?
Yeah,
it doesn't affect someone with the money and the resources.
That's potentially it. I mean, interestingly, so we're quite conscious that like I was saying before, there's not very many specific African snakes where there's specific antivenom that's been developed, and there was one on the market. But then it was withdrawn and without getting too political and offending people, it probably ultimately came down to the financial aspect of it. And actually, one of the organisations who's one of our partners, they're doing some work with the Wellcome Trust to essentially try and get that particular antivenom back on the market, as it were, because it's needed, and there is that need. But there's always that challenge between from a farmer point of view, it's shareholders' bottom line, isn't it? And it's neglected tropical diseases, and I think that's why the WHO highlights them so much, because actually, if you do zoom out and look at it on a global level and see those absolute numbers of who's being affected, they're vast, aren't they? And
ginormous numbers. And the, as I said, the geographical spread is only growing with climate change. So this is why I think it's a really important issue, and one where the work that you're doing with this to highlight some of these things as well is so important, because it does bring it front and center. Who else is involved, by the way, with the expedition, and what other partners have you got? Anyone you want to give a shout out to?
Yeah, so there's who have I said so far? So I don't want to leave anyone out.
You mentioned Hugh.
Scott,
there's
Hugh,
Ben.
Scott, Ben. There are 2 Jameses. So we've got James Perry, who is he's the executive director of the Virtual Doctors, but he's been involved as a trustee and through various other guises over time as well. We've also got a chap called James Dyer. He's sort of our expedition logistics expert. So he's done a lot of work with British Exploring. I don't know if you've heard of them. They're a youth development organisation based out of the RGS that takes.
Sounds amazing.
So I've done a bit of work with them as well. They essentially take young people who might not otherwise have the experiences to do cool things in the outdoors, and they've got evidence. They exist since 1932, I think. So they've got like longitudinal evidence that people who went on a trip, 50 years ago, they can pinpoint that experience is what has made me where I am today and things. So we've got him coming on. We've got Scott, as I said, and Alice, who is the founder of the Solite. We've also got Wilson Muba, he's from our Zambia team, so he's coming along. He's one of our main main guys in Zambia, so we wanted him to come along as well. I think that's really important, and we've got some other members of the in-country team joining us as well. I think that's everyone. I'm going to have forgotten someone, but maybe we can check in a minute because the screen's turned off. But,
have there been any sponsors that you've kind of like engaged with, people that are helping you? Obviously, you've mentioned about the kind of like the transportation and all the logistical challenges that you've faced.
Yeah.
Presumably, someone's going to have, it would be beneficial for someone to lend a hand with this stuff, right?
For sure, yeah. So yeah, we've been really lucky with sponsors so far. We've had some from Microfarm, who they're the organisation I was saying about, who are redeveloping the antivenom for it's called Fav Afrique, for the African snake antivenom. We've had EMATS, who are an organisation that provide medical cover at events, who've been really generous. Our whole range, our medical kit is being provided by Mir, who are a really cool company providing like medical kits to Sky News, BBC journalists, all sorts. Prometheus Medical as well, who provide sort of medical training. So a whole bunch of different people. We've also had Grail provide us with some pretty good water filters so that we don't get any illnesses ourselves and things, and various campsites and other organizations in Zambia as well. So we've been really, really lucky. We are still raising money with this. It's surprising how much things cost. Like, so this is a not-for-profit. No one is making any money out of it. It's all on making the actual project happen and things. But it is surprising how it all adds up pretty quickly.
I can well imagine something like this is an enormous undertaking, and multiple people, 3 weeks. You're going to have, as you say, you're covering 2,000-3,000 kilometers.
Yeah.
It's it's a significant investment that's required.
It is. Yeah, significant. Yeah, investment financially and also time-wise. But the nice thing is that I think if we'd have done this 6 months ago, we'd have had a very different conversation when I'd be like, oh my word, I've got so much to think about in terms of the logistics, trying to get funding, sorting who's coming, who's not, because the expedition team has also been fluid, having to, you need to be able to take time off work and commit to these kind of things as well. But I'm now really happy that we've got a really good team. Like, most of us have booked our flights. Like, it's happening. It's a thing. It's definitely happening now. We've got our camera guy, Jack. I didn't mention Jack before. So Jack's our camera guy from the States, who's going to be documenting it all. So we've got this really cool team.
Mm-hmm.
We've got a way of delivering these objectives. We'll have some good outputs out of it. And yeah, hopefully it will stimulate discussion, raise the profile both of virtual doctors. So like another one of our partners is On Call Africa. So they're another Zambian charity who we do quite a lot of work with anyway. So yeah, lots of cool things happening, and it's coming together nicely. I'm pleased that we're not flying off next week because there's still a few more things to sort. But given that we're going in September, it's going at that right sort of pace.
Crossing the T's, dotting the I's.
Exactly.
With the expedition as a whole, one of the questions that I was going to ask you was, what are the ways in which you're going to measure the success? How are you going to quantify, the impact that you're having?
Yeah. That's a really good question, and yeah, we touched on how that is really important. So the main impact measures that we're hoping to look at is probably going to be through the education. So we want to, first off, before we do it, get an idea of what people's baseline knowledge is for both trauma and snake bites. The issue with, snake bites definitely, but also trauma is that there's a lot of myths potentially on what the best management is. Certainly for snake bites there is, with whether you should use tourniquets and different things like that, and we haven't even got into sort of health beliefs and traditional health beliefs. A lot of the time the reason that outcomes are maybe not so good is because of herbal medicine and things like that. Now I don't want us to go in and be like, we're the experts, this is what you should do, don't use that, because that's like someone coming to me and say don't use antibiotics because I think this.
It's always a fine line.
It's a fine line. The idea is that we're not going to be doing that anyway because it's in partnership with the Zambian organization, but it's more going to be about empowering the local clinicians to better have those discussions. And they know a lot of this anyway. It's more just formalizing it and assessing sort of their knowledge and how we can help support them. It comes back to support, like we were saying before. But yeah, the main terms of outcomes for that is looking at how much of an impact that training has had. Are we getting? So the nice thing about our virtual doctors app is that we can then interrogate all the data that we get and be like, oh, before we did that training, we had a certain number of snakebite referrals. The information that we got about those was maybe not so good, and maybe the management was not so good. And it comes back a bit to the difficulty with data, because you might say, well, we're getting fewer cases, so that's a good sign, yeah, because that means our training is successful. Or does it mean that there was actually fewer snakebites? So it's hard to evaluate things. I'll make no secret that it's difficult to evaluate because of a lack of data, and also partly because clinical officers are overwhelmed. Coming back to the number of doctors per capita, the number of patients they have to deal with, because this is often one of the frustrations, perhaps, that some of our NHS volunteers, because they sort of answer the cases and they're like, oh, I'd really like to know what happened to that patient, and we can get kind of very crude outcome data, like that patient was discharged or this and that happened, but there's just not the manpower hours or time in the day.
Yeah, there's not the touch
to
point.
get a lot of it, and that's something that we've been really aware of, because we want to know whether there's any difference. So we're probably going to try and do it so that we have pre and post training outcome data, so surveys on knowledge and that sort of things. But we're also developing, for the snakebite specifically, a proforma that looks at why a decision was made, so we can understand what the thought was as that patient with a snakebite was being assessed, and then look at, is that correct or not, and how does that link to the training that we've put on. We hope that then that shows that the training has showed that they assessed according to XYZ and identified that particular toxidrome, and then did this, and this, and then that provides the evidence we need to then apply for more grants and hopefully roll that out to another district or within Zambia and things.
Yeah, so you have a sense on quantifiable metrics.
Yeah.
Is there something that you're going to do in practice post the expedition, in terms of, obviously you're going to be continuously monitoring that data, you're going to be looking at things. Are there other things that you're going to, and ways in which you're going to be engaging with?
Yeah, I mean, so the nice thing about it is that the expedition obviously can only be a snapshot given the time that we're going there for, but I think this is where it comes back to, we're not just doing this in a vacuum. So we have a team on the ground in Zambia who can follow up some of the training that we've started. They can continue with that monitorship. Our partner OnCall Africa also has a presence in certain areas of the country where we maybe don't have so many clinics, so they can get involved and things there. And a lot of it is starting these little pilots, cascading that knowledge, and then hopefully getting enough data that we can then, so we've got connections with the Ministry of Health. We've always been, everything we've done has always been in kind of alignment with their priorities. So then the idea is that we present this information to the Ministry of Health and say, look at this pilot, look what it's done. With your permission, can we extend it to here or do that sort of thing? And I think that's where the longevity comes into it. Yeah.
I think that's going to be one of the really key and important things, is that you see that continued kind of the spread of information, right? The education part that is such a crucial component of the expedition.
It is definitely.
Is the part that it's difficult, as you say, to measure it, but it's the part that you'd also want to see.
Yeah, I think that's right. And it's when we came back to the planet, it came back to sort of, initially it was an idea of, let's go and visit some clinics, do a bit of traveling, and then it needed some skeleton to hang all these ideas off, because otherwise it was always going to be a hypothetical idea that would never have happened. So it was good that we had that initial, let's go and do this. But the nice thing is that off that skeleton, we were like, okay, we've hung off the snake bites, trauma, the lights, and we've got a few other interesting discussions as well. So we may be doing a bit more scientific work out there as we go around, but I can't tell you too much about that yet. That's a watch this space. But the nice thing about it, I think, is as it's grown, it's obviously not got a huge presence or profile, but as it's getting a bit more of a presence, people are like, oh, that's quite interesting. Maybe you could look at doing this, and this with the trip. The difficulty is that we only have 3 weeks. We don't want to stretch ourselves and overcommit to too many people and then, not deliver on things, because that's equally dangerous. It's not a great thing to do, but you want to have an impact rather than just do a few things I think a few things done really well is better than trying to promise everything to everyone.
I could not agree more. Focused, consistent effort.
Yeah. But at the same time, if something cool comes along that we think can benefit the expedition or indeed the wider global health community as well, then for sure that's an interesting dialogue to have.
Yeah, I was going to ask about that in terms of the wider global community. Are there particular things that you're hoping to be able to play back from the expedition, from some of the work that you're doing? Obviously, raising awareness of certain conditions and other bits and pieces. But are there other aspirations that you have in playing?
Yeah, that's a really good question. I think that one of them is just raising awareness of, and you've probably heard a bit about this from Scott, but how telemedicine can be quite a useful resource.
It could be transformational.
Can be transformational, as can harnessing the sun. Particularly when there's issues with climate change and stuff like that, as we were discussing.
And dams that provide electricity where there's no water.
Exactly. So I think those are two key things that you can extrapolate to other places. I mean, from the virtual doctor's perspective, we probably get at least weekly emails saying this is a really good service. How can we, can you help us in this country or that country? And we say, oh, we're a small charity, so we don't have the funds to do that, but we can certainly explore how we went about it. And normally the bottom line is get some sort of memorandum of understanding with a Ministry of Health, because you can't just go into a country and start doing things.
You provide the framework that they can then execute.
Yeah,
right?
Precisely. So I think, raising awareness and starting those kind of discussions is quite interesting. I think the other thing, and this is something that during COVID, the whole world became a bit more connected in terms of global health, and everyone realized that there are loads of significant global health issues, but that's all disappeared, I think.
It blows.
It's gone a little bit. So we're trying to bring that whole narrative back a bit, and we're not just isolated here. There are actually all these other global issues that we need to kind of, and it sounds cliche, doesn't it? But we need to come together and actually address some of these. So if it can get people talking about some of these, and particularly the neglected tropical diseases, then hopefully that's another good outcome.
It's no great secret to anyone that works in the medical field that digital is the longest lever that we have in order to tackle and level people up in terms of outcomes and health.
Yeah.
For the entire diaspora of patients, whether they're even in our own country or whether they're in America or so-called developed nations, as opposed to others. Leveraging the power that we have at our disposal could have a massive impact in terms of education, which is the cornerstone for preventative medicine, health outcomes that are positive. And then, with the people that you're engaging with, the clinicians and stuff like that, that in and of itself is huge. And then you layer in the fact that you've got solar power, you've got solar powered telephone masts, you've got lighting systems that can be daisy chained, you've got the knowledge that goes on top of that, because those clinics then are safe places for people to go, because they can reach them without getting run over by not having street lamps or lighting. It all ladders up.
It does, exactly. And this is probably jumping the gun a little bit, but we're sort of hopeful that almost this expedition is a bit of a pilot to what is possible, and it doesn't necessarily need us to go on it next time. One of the things is, well, could this all just be done in country? Potentially. What now we've got with this expedition, we put this framework in place, and that's the really nice thing about having Scott and Alice involved. Actually, we hope that will form a meaningful partnership, so that each clinic we onboard, we can then be like, okay, here's your telemedicine, here's your light, here's your snakebite training. As a much more sort of involved package, which would be great.
But I love the way that you phrased it right back at the beginning of our discussion, where you were saying about how you try to make yourselves redundant. Yeah. Because ultimately that lens and the way that you approach it through that lens is so important, because that's exactly what you should be doing.
Exactly.
It's about giving people the knowledge that they need to be able to act in a way that treats patients in the way that they need to be treated and empower their community to raise themselves up. You don't need to be there to do that.
No.
You could do the pilot studies that you're doing, and then, as you say, you've created the framework. Each different country probably has its own nuances and intricacies.
Definitely.
So there'll still need to be probably those individual ones. But the learnings that come from it, you then apply that much more broadly, and it's ripples on a pond.
For sure. Yeah, that's a really nice way of putting it, I think. Yeah.
I've got an okay turn of phrase when it suits me. If people want to get involved, what can Joe Public, the untrained, such as myself, do?
Yeah, I mean, if you want to get involved, so we're still actively fundraising. We're probably 80% of the way there in terms of what we need, which is great. And like I said, it's not for profit. If it does push into profit, then we will essentially just give it back to the charity or some of our partners, any of the charitable organisations involved, really. So we have a website which is livingstonrevisited.com, and there's a link to our GoFundMe there as well. Just spreading the word, really. Remembering that there are all these neglected tropical diseases. It doesn't have to be unique to this expedition. Start talking to people about some of the health challenges that maybe they don't know about. I think that in itself is a good thing.
Yeah, and if you can get one key message out to people, what would it be?
Oh, that's a tricky one, isn't it? My one key message would be that I think it's important to think of us as a global health. This sounds like a huge cliche, doesn't it? But at the end of the day, one planet. There's so many global health issues, and we're in danger of just living in this little silo. And I think, whilst this expedition is tackling a whole bunch of different things, I'd hope its end outcome is having that dialogue about these wider global health issues.
Love that. Yeah, I think creating that global community of healthcare is really important, and it's something that we haven't, even in our connected digital age, we haven't found a way to.
Not quite, not yet.
Figure out just yet, but hopefully there's always hope.
For sure.
Daniel, it's been an absolute pleasure having you. Thank you so much.
Thank you very much. It's been great.
Hey guys, thank you so much for tuning in, and I really hope that you're enjoying what you're seeing so far. Please do give us a like and subscribe to the channel so that you get alerts on future episodes. And if you have any suggestions on things that you'd like us to cover in the future, leave your feedback in the comments below.